Hello, everyone, and welcome to the 2020 Oregon Rural Health Conference, presented by the Oregon Office of Rural Health. My name is Rhonda Ann Gerst, and I am the Rural Health Clinic Program Manager and will be the moderator of this session today. First, I would like to thank our partners, Gold Partners, All Care Health, Oregon Rural Health Association, Silver Partners, Eastern Oregon Coordinated Care Organization, Oregon Association of Hospitals and Health Systems, and River House on the Deschutes. Bronze Partner, RQI, and our Copper Partners, Westcom, American College of Education, and Inquaseq. Their continued support during these difficult times has made it possible for the Office of Rural Health to offer the conference and workshop at no cost to you. Session evaluation. After this session, you will receive a survey. Please help us continue to make improvements by completing the survey. In addition, this is how you will receive your CE credits, and you will be entered in a drawing to win a $100 gift card. To present Adopting Telehealth, our experience and lessons learned, please welcome Orion Falvey, Executive Director and Co-founder of Orchid Health, and Max Janasik, CEO of One Community Health. Orion, Max, the floor is yours.
Thanks, Rhonda Ann. Appreciate that introduction. And, we'll go ahead and jump right into the slides unless you wanted us to do some quick intros. All right. So Max Janasik, I've been with One Community Health for about a year now, a little over a year. We are a nonprofit federally qualified health center in the Columbia Gorge. So we have sites in the in Hood River in Oregon and also in the Dalles. And we serve patients that are both in Oregon and in Washington, since we're kind of a border clinic. And about 17,000 patients and about 200 staff, just to give you a sense for our size and our history here. We'll go to the next slide, Rhonda. So telehealth came at us pretty quickly. Obviously, with COVID arriving, we had not done telehealth prior. We had signed an agreement. We're an Orion Epic client. We had signed an agreement to implement telehealth in 2020, but had actually not started the implementation. And then with COVID's arrival, we realized how quickly we needed to get moving on virtual visits. And so within a matter of a month, we were able to accelerate our implementation and activity to really launch telehealth and virtual visits. By the end of that kind of first month, we had gotten to 70% virtual visits. And by virtual visits, I'm combining both telephone visits and video visits. And you can see in that little parentheses there, we had about 28% of them conducted by video in that first month. Kind of since then, obviously more patients are comfortable coming into the clinics, and we've been seeing a lot more folks there. And so we've seen the total virtual visits drop quite a bit. We're down to about 23% virtual visits, but we've been really heavily focused on optimizing for video. We think it's a better experience. We think it's, both for the patient and the providers. And we'll talk a little bit more about that here. And this has been kind of validated. This survey data just came out, and it covers the period, I believe, from March to August. This is from the Crossroads group. 40,000 patients across the nation were surveyed, and there's a lot of rich detail in that survey. These are just a few highlights, and really what it reinforces is that patients love video, and you'll see in this that throughout here that they love it for certain examples even more than others. But video is whether it's their overall satisfaction, whether they are more likely to refer you to family and friends after a visit, and their overall perception of their quality and experience all score higher on video than even in person, which is somewhat surprising. At least for me it was. And then substantially better than telephone in some cases, like in the referral intentions there. So for us, the data, certainly validating. Obviously, we didn't have this when we started, But what we did have was a realization that even though there were a lot of options for video visits or telehealth virtual visits in general, what we really decided was we wanted to get people into a secure channel and one that we would use for more than just video visits. And that is, for us, that's our MyChart application, which is part of our Epic implementation. And so within our MyChart system, we do more things like lab results. We can do messaging with patients, secure messaging. They can look up, previous visit history. There's a variety of information in that application, whether it's through the app or through the portal. It's also a secure launching point to a Zoom-based interface, which is fully HIPAA compliant. So our goal really was to get people to a place we intended to use on a long-term basis, rather than implement, maybe other alternatives that were technically allowed but weren't really our long-term strategy. So you can see from our data here, in the first couple months, we had a pretty good hockey stick-like chart. Everybody loves the hockey stick charts, right? But then it kind of tapered off a little bit. And we've kind of been steadily improving our MyChart activation. Still, we have a long way to go. But this has been our emphasis and focus. And, it's almost similar to like an early adopter curve where you get that first 10%, 20% pretty easily, and then you got to work hard for the rest of them. And so that's been kind of our experience. We've thrown a lot at this, certainly staff training, big part of it. We hired some interns to help, in particular with that kind of conversion, getting people ready for a video visit. We've also did a bulk activation. So for instance, in MyChart, you have to activate. It's not really as easy as I would like it to be. So we send people a text message and auto activate that, and then they have to confirm that and answer some challenge questions. We've done some techniques to try to drive that adoption. And, I think COVID brought us staffing challenges as well. People had to be out for various reasons. So a lot of this was, we had to figure out a way to systematically train new staff who were covering and do things like that. So these are a few of our tactics or techniques. The other thing I'll point out is, as we've gotten a little more sophisticated with this, we now have some filtering. And so it's a little hard to see on the screen, but we can now filter, for instance, language preference, race or ethnicity data. We can look at whether someone is a migrant or seasonal farm worker. So we can use this data to look for kind of where are there disparities in who's adopting MyChart. And that allows us to try different campaigns and approaches for communication. So that's a little bit of an evolution since where we started, which was kind of like, let's get everybody on it. We could be a little more refined in finding those disparities. So I talked about video, and this is really where we're evolving our focus and really trying to drive video adoption. This chart also looks a lot different than what it looked like when we started. When we started, we said, oh, we have 70% virtual visits. We were, patting ourselves on the back, but then when we double clicked, we realized, hey, we're only at, at the beginning, 28% video. And we're like, wow, we have a lot of work to do. So what we did was we started to carve out our visits, and we looked at what are their audio only visits, what are the video visits, which ones are paid, which ones are unpaid, which ones are in person. And we started to get a lot more sophisticated in analyzing kind of what is really happening and what we could do about it. And we realized we clearly had a lot of work to do to get people to adopt video. And so, we threw a lot again at it from a tactics standpoint. We implemented a concept we call the tech check, which is before the visit, kind of somebody's reaching out, trying to get that patient ready. We haven't always been able to staff that, so it kind of comes and goes a little bit depending on where we're at in terms of staffing levels and capacity. But it is something we think has a huge lift on video when we do deploy it. We definitely have been using more and more of these instant messages for things like PCP to behavioral health, warm handoff. Some of our behavioral health providers are still working primarily from home, and we found that behavioral health has had a pretty good uptake on video. People seem pretty comfortable with it. We've also, set up an outbound call team. So we took some of our TAs, our team assistants, and deployed them to help call our vulnerable patients who might be a little less familiar with some technology, but also had a lot of conditions that might put them at risk with COVID. So wanted to make sure, they had an engagement with our providers. They knew what they could do to stay safe. and we proactively called them. We created a little scoring algorithm to identify risk, and then we called down in that order. Some of the other things that I think are important, obviously, with this is, really the ergonomics as well for staff. At the beginning, especially, folks were spending the majority of their day on these video visits and didn't always have the greatest ergonomics at home. So having, and I feel like we still have work to do there, but really supporting staff that way. Also, simple things like, the right kind of noise isolation, earbuds, things like that, now that people are back in the clinic, when they are doing a video visit, making sure that they have a place that works, that's quiet, or has great sound isolation. Otherwise, you start getting, you can hear talking in the background. So just some subtleties, I think, to pay attention to. And then a big focus has been kind of on sharing the best practices amongst the staff and from other organizations. And that's kind of why we are participating today as well. But also, we really like to learn from others of what's working, what's not. So, in that process, in that shared learning, one of the things we do is we look at, well, who in our organization is having the most success with video visits? And we quickly identified we had a medical assistant named Christina who was really kind of hitting it out of the park. She was getting over 70% of all visits video, all virtual visits that she had were going video. And so we now had the data and said, Christina, what's working? What are you doing that's so different? Because you can kind of see that little chart with Christina there, and then the rest of the rest of our medical assistants and what their virtual visit rates were, or video visit rates were. And Christina said, what I kind of do is I talk to them, I talk to how important it is that the provider wants to see them on video, that we are now switching over to video visits, and Dr. McKenna in this case would love to see you on video. And that alone, she said, drives the majority of it. The most people, in her little quote here, 98% of the time, because the provider wants to see them on video, they're willing to give it a try. And these are folks who, they're not necessarily spending their whole day on Zoom like some of us are. So this might be their first time ever trying a video visit, so they could be apprehensive to see themselves on camera, or maybe they're afraid of the technology. They're going to make a mistake, and they are afraid of that. And Christina's found ways to really help them. So part of it is preparation, making sure that you are ahead of the appointment, reaching out, getting them comfortable. Part of it is in the messaging, really, in that the provider does want to see you via video. And just that the attention to those small details has made a huge difference. The other thing that we're doing now is Christina's going out and training other folks on these techniques. So taking some of those best practices really and spreading them. She also has, told me that sometimes if someone's struggling, will see if a relative or somebody else is nearby that can kind of step in and help out. So a lot of times, families have others, at home that can figure out little technology things, like maybe the app is having a problem, maybe they're out of memory or something, need to clear some of their videos off or their photos, little things like that, getting support. But again, it really comes down to some of these subtleties that make the difference. Some of the other use cases, I'll cover a few of them real quickly here. One is, we've had some success with kind of these comprehensive geriatric home visits done virtually. So some of our providers have mentioned how valuable it is to actually see the home, and having patients, for instance, demonstrate activities of daily living in their actual environment. You can identify maybe some risk factors, some obstacles in the home, having them show you their pill bottle, for instance, or how they're organizing their pills. And it actually creates a whole new way of engaging with patients and really providing a different level of support. And so this idea of video is making a traditional in-home visit may be very challenging logistically to pull off, especially with COVID. But to actually be able to do that with video, we found to be quite successful and have great patient feedback on that as well. With the beginning of COVID, this was a big one for us, this use case, which is, we called it tele to tent, was kind of the name we used for it. But essentially, it was a video visit, and then if there were there were hands-on needed for the patient, we could direct them to an outdoor space we had dedicated to doing things like listening to lungs or doing a COVID test or other activities. And this also helped us because we did have some providers who had some health challenges, or some of them were expecting a child, and so they were, not really able to necessarily be out there. But by being on the video, they're actually able to, evaluate the patient and then navigate them, for instance, to our medical assistants or our nurses to do some other testing or checks. So it actually helped us scale our care which otherwise we might not have been able to deploy some of those staff. It also, reduced the risk to staff and patients. And I think with with winter coming, and this will kind of reemerge as a use case that we use more so over the winter months. The next use case that we've had a lot of traction with is really behavioral health, and I think it makes a lot of sense. It's and the data backs it up. Patients seem to really like using video for behavioral health. It's definitely substantially better than telephone only, to be able to read the reactions of the patient and get that kind of nonverbal feedback, which is so essential in engaging with folks. And so we've really had some success too with this instant messaging, where if a PCP identifies a behavioral health need, and certainly with COVID and social isolation and just everybody's patterns disrupted, the need for behavioral health is quite high right now for everybody, I think. And so picking up on those cues and be able to reach out to behavioral health and essentially hand that patient over at some point when the standard medical visit's completed, can work really well. And so this continues to be an area that we're spending a lot of energy on, and for the most part have gotten very good feedback on it. The other interesting thing is some folks, as they try video visits, they'll actually take that to the other parts of their lives. So maybe they never did a video chat with a friend or a family member in another part of the country, but it actually can help them reduce social isolation. Now they built a little confidence that, hey, this isn't too bad. Maybe I can do a happy hour with a friend, or check in with a family member. So we're seeing a little carryover into kind of their daily lives as well. Obviously, it's important that we pay for all this. And so one of our revenue cycle experts, Brett here, has a bunch of tips. I won't go into a lot of these tips, but you're welcome to really review these. And obviously, each payer might have a little different rules. There's some patterns you can see. We've tried our best to simplify this. The good news is I think there's ways to get paid even for phone onlys, because the reality is you can't always do video. And although, sometimes, they may change some of these rules in the future, but, for the time being, there's ways to get reimbursed, and there's different rules here that you're welcome to, and happy to share other information outside of this if you have questions on that one. All right, so kind of what are the key benefits to all this, these virtual visits? For one, especially now we're entering winter again. Out here it gets pretty icy sometimes. This idea of transportation being a barrier. We have patients that live sometimes hours away from the clinic. It really helps overcome that. We talked a little bit about that geriatric home visit, but that idea of a window into the home environment, very powerful. For patients, it can be a time and money saver. They don't have to take time off of work necessarily and drive and buffer that extra time. It's convenient, right? You can do it from your home if you're working from home, or if you're, you can work it in different ways. I think it creates an opportunity for new engagement. We've really talked about, getting more and more into kind of digital engagement, group visits, things like that. And we're working towards those models. This kind of paves the way with building comfort into that. I think no-shows, are historically a real challenge for us, but this almost becomes like an opportunity to recover a visit that might otherwise go as a no-show. For our medically vulnerable providers, it has allowed them to continue to practice, which is fantastic. reduces risk of infections, things like that, and also conserves PPE, right? You're seeing a lot of people via video that you would otherwise have to be fully donned in your PPE for. So definitely quite a few benefits. And obviously there's some challenges, right? Not all patients have the tech literacy. You got a bunch of apps. Sometimes you have to install MyChart and Zoom. That can be hard. So, making sure you have clear instructions, a team that can support them, leveraging family members. So these are some of kind of the tips and tricks we've deployed. The timing can be really tricky, right? You're trying to do this before the visit and get it all set up so that when the provider arrives, it's all dialed in. And so kind of making sure patients are ready and ready to go. Low bandwidth, we don't have Starlink here yet. So maybe Elon Musk will solve this for us in the next few months, but certainly out here, bandwidth can be super challenging in different parts of our service area. Obviously environment, we talked about that a little bit. There's some rules around interstate licensing that can be tricky. Like, normally our Washington patients were coming in to Oregon, so it wasn't really an issue. So we had to work through some licensing challenges. And then the coding and billing, obviously that's critical to the sustainability of this. And so we've done things like little quick guides so people know how to code properly and all of that good stuff. Well, that's it for my portion of this. And so I'll be eager to get people's questions after the end of all of our presentations.
There we go. Thank you, Max, for sharing Orchid Health's telehealth story. And thank you, Rodney Ann, for having us. My name is Orion Falvey, and I'm the executive director and co-founder of Orchid Health. And Max did a great job kind of sharing his FQHC's use cases and adoption of telehealth. And I'm hoping to add to that from a smaller organization perspective. Orchid operates 3 independent rural health clinics. Our smallest clinic is in Mackenzie River, and that's a team of 6 employees. Our largest is in Estacada, a team of about 15. And Orchid was founded with a clear vision for healthy rural communities and healthcare revolutionized, and our mission to provide people in rural communities with a fair and just opportunity at a healthy life. We're a team of 45 employees, and we serve about 5,000 patients with advanced primary care, mental health, dental, complex care management, and community health services. We're kind of a smaller version of Max's organization, maybe half or a third the size. You can go to the next slide, Rodney. So I'm hoping over the next 15 or so minutes that you'll be able to gain a good understanding of what led to our organization's telehealth success. I'm going to put an emphasis on the planning and preparation and kind of team engagement piece to not be too redundant to some of what Max shared. And then at the end, I'll provide my email and include some of our specific guides and protocols that we've created, and I'd be happy to share those guides with anyone who's interested. So the next slide. So I'd like to start by taking you back to pre-COVID times with a kind of a situational overview. If you could go back one slide. Kind of where Orchid was pre-COVID, and many of you can probably relate to finding yourselves in a similar situation. We use Athena EHR system. There's no built-in telehealth visit option there. Our past experience with telehealth, we had some experience conducting telephone visits, but no video visits. We are participating in multiple value-based care initiatives. So roughly 50% of our revenues come from non-visit based revenue, which was helpful going into COVID and telehealth adoption. And we had strong integrated mental health services, and it just launched a dental program. Some external factors, billing and reimbursement. Rural health clinics were unable to bill Medicare for telehealth services. OHP and some commercial plans were paying. Our communities, Mackenzie River, our smallest clinic, is our most rural community. and our communities had varied access to internet and cell service. And patient attitudes towards telehealth and virtual care. Many of our patients strongly valued the social connection that Orchid provided in the community. And so we knew that we were going to, our model was founded on relationship-based care. And so we knew a key component of telehealth would be how do we continue to provide that level of trust and relationship in our services. So then came COVID, early to mid-March, and we had to implement a rapid telehealth program expansion to continue to serve our communities. So this is where this slide kind of shows an overview of what did that process look like of quickly preparing a core project team and creating a telehealth project plan with an aim, measurement targets, milestones, and the specific steps to achieve each milestone. And we use a project management system, Asana, which has a free option or a paid option, and it's a pretty simple project management software that I'd recommend. And so we built our project plan. It took about a week to build our project plan. And then the next step was in mid-March to demo the top 2 or 3 telehealth platforms. And some of the commonly used platforms, we reached out to our peer community to get some feedback, were DoxyMe, a MyChart platform, Zoom, Doximity has a platform. They range from 0 cost to over $1,000 per month in usage fees. So we ended up choosing DoxyMe, their free version, which we still are using today, and it's worked fairly well for us. The next step for us in our implementation plan was to create the workflow guides and the trainings for our staff. And that's something that Max mentioned as being crucial to the tactical success, is creating, kind of being clear about what the operations look like, what the workflow looks like. So we put those together, and those are some of the documents that I'll reference later on. And then in late March, we tested out the workflows. We identified champions at each site, provider MA teams to test out the workflows, circled back around, kind of using the small scale test PDSA model that we used and we were familiar with other initiative rollouts. In April, we held full team trainings, sent out messaging to our patients, manually reached out to all patients on our schedule for the next several weeks to reschedule them, and measured our initial 30-day results, which were, we completed 350 or so video visits and just over that in telephone visits. So about 50-50 video and telephone. One key to success for us early on was making telehealth a company-wide priority for Q2 for us. So we made it our #1 objective, which ensured that it would get the leadership support and the face time that it needed. And so for us, that looked like holding weekly meetings where we checked in on the workflows, what was happening, what the challenges were, and then we took those lessons learned back to our teams. So that was kind of the quick initial month of implementing telehealth. Since then, we've been assessing our program, similar to One Community Health, looking at the use cases. Behavioral health has been successful. Primary care has been successful. And one of our targets was, can we, via successful implementation of telehealth, hit an 80% of pre-COVID visit productivity targets to ensure we're still serving our patients to a certain level of care, and supporting those engagement touches with our community and patients. And we were able to be successful in hitting that target via over 5,000 telehealth phone and video visits performed through the end of September. We carried out comprehensive outreach efforts via our front office RN community health worker team. With more visits done via telehealth, we found that some of our other care team members had more time on their hands. So we were able to redeploy them to really focus on outreach and kind of taking a population health effort, looking at specific high-risk patient groups, and continue to offer integrated whole person care to include virtual warm handoffs to behavioral health providers. And we're able to generate roughly 1 in 4 of our patients last month received integrated behavioral health care as part of their care received that month. And so that was, I think, Max, you touched on it. Even via telehealth, there's still the opportunity to introduce another care team member to support that patient with behavioral health needs or with complex care needs. And so we've continued to be very kind of disciplined and focusing on results and tracking what is happening and sharing that back with our team, and creating contests between our teams to really kind of generate ongoing commitment and excitement to the work we're doing, even though most of it shifted to telehealth services. Some of our challenges, connectivity issues have been a big challenge. One way we mitigated that challenge is we received a grant to provide tablets to patients that didn't have connection at their home, or maybe they didn't have a smartphone or a computer. And we actually kept some of those tablets at our clinic, and people would drive up to the clinic and we would meet them in their car and give them a tablet. If they were high risk and we didn't want to bring them in, we would give them a tablet and we would perform a telehealth video visit, them in their car in our parking lot, which had Wi-Fi hotspot, and us in the clinic. We did that with other hotspots around the community too. So we handed out tablets and we shared the community hotspots with our patients. And there's definitely still challenges if someone didn't have a vehicle or a way to hold that visit at the hotspot. But it was a successful initiative. Another challenge with we got behind on labs, immunizations, and wellness exams. Looking at those services that you really need in-person care to provide. Since assessing this, we've held specific kind of lab days in one of our outbuildings and gotten creative with some of our other efforts to provide these services. And then the billing issue was a really big barrier for us, and trying to understand the ever-changing coding and billing regulations affecting rural health clinics was a challenge. And we had to hold all Medicare claims for several months until we identified kind of what that final code was going to look like and what those rules were. We do have a billing director that we're lucky to have, because it really was probably a 10-hour per week job of just maybe 20-hour per week job of just trying to stay up to date and create that billing and coding guide. But that's pretty ironed out now. So I would say there's guides out there. Max, it looked like you had a great coding and billing guide. And so no need to reinvent the wheel. Clearly it might change based on what happens at the end of this year and moving into next year. And then lessons learned and keys to success. If you go back to that last slide for one more minute. Like I shared, the frequent weekly check-ins to provide support and review reports was really critical. We had identified this with other quality improvement initiatives and new program rollouts, that you can put so much work into the planning and the creation of the policies and training manuals, and you hold a big training, and then you go to implement and it gets forgotten about if not closely monitored. And so we knew with telehealth that to support our teams in the successful adoption, we were really going to have to be checking in with them very frequently and consistently, and getting their feedback and trying to remove any barriers that they were encountering. And then also a lesson learned was really not being afraid to reach out to our peer networks to share ideas and just provide reassurance that, you know, this is the environment we're in. And talking with Max and being like, where are you at with the breakdown of in-person based on the COVID situation at the community level, the state level, the national level? Is this about kind of benchmarked where we should be at? We were at that 50-50, 50% virtual phone and video and 50% in person for a while. early on, we were almost all virtual. So really, there's a lot of value in the shared learnings as we navigated through that. So our kind of big picture, zooming out to the 30,000-foot view, we broke it down into kind of a three-phased program and implementation. The first being March through the end of September was this kind of quick bare bones ramp up in response to COVID and creating the policies and procedures and trainings and trying to continue to best serve our patients and keep our clinic doors open and hit that 80% target. So we've checked that phase one off. We're looking at phase two now, which we just started, and that's really looking at a more integrated, robust telehealth platform. I mentioned we're still on DoxyMe, which isn't integrated into our EHR system. It works well, but from a workflow standpoint, we're looking at a platform that can offer group visits and has better interoperability. Definitely continuing to circle back around and meet with our core project team and look at best practices. Max, you shared about why are some MA provider teams performing much more video virtual visits versus telephone, and kind of what are they doing that we can spread across the clinic. Launching telehealth group visits and an emphasis on video versus phone is going to be important for phase two. And then phase three will be to conduct kind of the elephant in the room for us still is the lack of connectivity and internet access in our very rural communities. So phase three will be looking at conducting a broadband enhancement research and implementing enhanced connectivity across our communities, in each of our communities. Part of phase two for Orchid includes kind of looking at the larger implications of telehealth. You know, it's completely changing how we provide care and making sure we're not just kind of reactively staying kind of caught up on telehealth and using it as a tool just to continue operations, but looking at how can telehealth be part of a larger transformation that is happening and is necessary for primary health care. And so for us, that looks like completing what we're calling the Future Care Model Design Initiative over the next 4 or 5 months, which one component of that is looking closely at, if you're looking from a kind of customer-driven, patient-driven standpoint, what is that breakdown of in-clinic services versus out-of-clinic services? Looking at asynchronous virtual services, synchronous face-to-face services, home visits, community health services, and really trying to think about what do our care teams look like, what do our facilities look like in this future world. And that's kind of what I'd like to end my presentation with, is that proposal of kind of challenging each of us to think about how we can workshop that idea within our organizations of what would our clinic operations look like if greater than 50% of patient services were provided outside of our walls? Because I truly feel that is the future, and that is what patients want, as some of the data is showing that video visits are successful and people appreciate what can be done over video and the strengths of those visits. Like I mentioned, some documents available to share are our telehealth policy and procedure, which is like a 4 or 5 page document, our coding and billing guide, and some of our workflow guides as well. I'd be happy to share, so I hope to hear from some of you and look forward to answering questions with Max when we go live with this.
Thank you, Orion and Max, for your informative telehealth presentation today. We will now go to question and answer session. Hello, everyone, and welcome to the live Q&A portion of this session. Please use the Q&A box to add your questions for the presenters. Let's start with our first question. Max, Orion, can you hear me? Are you ready?
Yep, we're here.
Okay. Now that telehealth is here to stay, in my opinion, how can we help get better connectivity to and for our patients and their families, as well as less expensive options for our clinics? A year ago, we'd all have said it will take many years for adoption. Boy, were we wrong. Can we now step back and get infrastructure improved at the same speed?
I'll take a stab at it. Yeah, I think that's the big question. I just had a discussion about that with my clinical team yesterday, and I'm not sure if it's weather related or not, but we're having more and more connectivity issues with video, and we're having to think about alternative means. My short answer is we're looking at a two-pronged approach. The first is there's a lot of resources out there, almost resource and funding overload for broadband enhancement projects. Even prior to COVID, there was a lot of resources for getting rural communities hooked up. I think what we're seeing is the last mile issue of, like, our clinic has fiber and our clinic we can do video conferencing and has pretty good connectivity, but our patients in their homes, that last mile. So like these rural communities are getting hooked up with fiber, but not to people's homes. And so that's where we had to kind of take a hotspot approach of giving patients tablets and then they could come to our clinic parking lot. It's not ideal at all. I think, Max, you shared the value of being able to see someone's home is definitely something that is extremely valuable. So, but there are solutions out there. I've spent, as we kind of look at our three-phased approach, I've spent some time researching the funding available and what solutions are out there. And I think a key partner is going to be reaching out to our internet service providers in our communities and saying, we want to go after these multi-million-dollar grants to solve this last mile issue and be able to provide telehealth. You're the subject matter expert. Like Orchid, we don't have an IT person even. Being a small rural health clinic, it can be really overwhelming and challenging. So I think partnering with a local internet service provider, they're going to get a payout from the grant funding that's out there. The second part, so the first one is just to be daring and kind of try to go after some of the big chunks of federal funding that are going to help solve the last mile issue. The second is utilizing texting and phone visits. We're having to do more phone visits because we'd rather do a phone visit than struggle for 15 minutes losing connection for patients that we know don't have reliable internet access. And there are funding issues with that as well. So there's a better answer.
Yeah, I think you nailed it, Orion. I mean, the only other thing I would say is that there's no magic wand yet, right? Like, we are getting some grants to, give out devices, but if you just can't get broadband in your area, that's a serious limitation. And I was only kind of half joking about Starlink because that does hold a lot of promise. There is no necessarily geographical boundary, and we've already seen it used in the state of Washington as part of the emergency response to the fires. So I'm hopeful that as more cost-effective, solutions like that become available, that we can really give our rural folks, the right kind of access.
And I think it's going to be kind of the long game for the broadband issue of it's a 2-year process if we're really trying to, it's such a big challenge. So it's hard to invest in it right now, knowing it's going to be helpful 2 years from now, maybe. But I think we need to, if we want to be kind of ahead of the game and proactive.
Thank you. For clinics who struggle to implement telehealth options for physical health, how do you recommend increasing provider buy-in, handling preventative care, A1C, blood pressure, vitals, helping patients who are not technically savvy?
Yeah, I'll start and then Orion, you can jump in. From a provider buy-in, for us at least, it was pretty easy at first because there really wasn't any other choice. But I think showing them, having stories shared by other providers of success has been the key for us. And when you hear some of the impact and actually getting the patients to share some of their perspectives can go a long way with building buy-in. We try to share those stories as soon as we get them, and you're driving towards like, how did this really change someone's life? And we have examples of folks who just wouldn't have been able to come in and were at risk of a stroke or other things. So having those stories generally, I think, gets at the emotion and the heartstrings rather than just the fear of trying something new. And I think then the other item is really the support, making sure people have the training, sharing the folks who are really good at this, having them help others. So some shadowing or some sharing of best practices all can help overcome some of those challenges.
Yeah, I think that covers it. I would really emphasize celebrating successes and sharing the stories that drive the work we do.
Thank you. How can we make quality telehealth available to individuals who do not have video call capabilities?
I think thinking about phone visits as a really productive, viable option, and also texting. And that, yeah, I mean, it's kind of this same question of playing the short and long game. There's some models out there, some options like providing tablets to patients for the kind of short term and trying to identify hotspots in the communities, or thinking about partnering. I've heard of some programs that AT&T and some of the cell carriers offered free data, and if you could kind of rely on data versus Wi-Fi, sometimes that can be a successful strategy. Instead of giving a tablet that they have to connect to Wi-Fi in their home, it's a tablet that has data, and they can use the data, and trying to get some grant funding or even partnering with an AT&T carrier.
Yeah, Ryan, I think that's what you guys did with the hotspots with the clinic was a great idea. I mean, I wonder if there's some way we could have almost like a Google Maps of free hotspots or something that we could find and give out to patients who just don't have access at home. But maybe the drive all the way to the clinic is excessive. Maybe there's something in the community. That'd be an interesting collaborative project, that maybe like Ochin or somebody who's really invested in this area to help spread it nationally could help us with.
Yeah, and hotspots, but even taking it a step further, and I know the VA launched a program a few years back to partner with churches and libraries if they had private spaces that patients could come in and access a computer and receive telehealth services. So, even a physical space, I know with COVID that can be tough, but if it's kind of, I don't know, there's funding out there to make it happen. It really is just going to take thinking outside the box and thinking about what level of investment we want to pursue for a kind of temporary Band-Aid solution when we all are so hopeful that, people are just going to have connectivity in their homes. That's what we want.
Beyond telehealth, what are you doing to deploy technology different to improve healthcare?
Well, I'll start with that. Orion hit on texting. That's been a big one for us because we think that, texting is very accessible for most people now. So we implemented a solution called Well for that, and we've seen great utilization of that tool. We also, we think things like, online scheduling and other technologies, that people are comfortable with in other aspects of their lives. We're working on bringing those to life. We do some basic stuff with JotForm now. And we've had good success with that for like large events. So if we were doing a COVID testing event out in the community, we could let people sign up really quickly online. They could pick their slot rather than, bombarding our call center with all those incoming calls and waiting for a long time to get scheduled. And then I would say, like, for us, the real focus forward is like thinking about how do we work with groups of patients and support them and really build those peer networks outside of the visit. So, how do we work in between the visit and things like, whether it's healthy eating, whether it's, diabetic awareness and learning, these are things we don't have to do one-on-one over and over again. They almost are really better delivered in some ways, aspects of it in groups where you learn the tips and tricks from others. So, we see digital, video playing a big role in that, but we need people to be able to get on video in order for that to be feasible. So we think it's very strategic long-term.
Thank you. Let's see. What about utilizing Google Currents communities to connect the community?
I haven't heard of that. Have you, Max?
No, that's not something we've used. I'm not familiar with it. And we have to evaluate it, is it HIPAA compliant? And, so those are the kind of things that we would look at when we're looking at community software. And that is something we're looking at right now, is how do we have video content, message boards, where people can be communicating both with each other, but also with our providers outside the visit. So we'll take a look at Google Currents to see if it's HIPAA compliant and useful, but we're doing a full evaluation right now of different platforms for that.
Yeah, that's a big interest for us as well, is what kind of virtual communities can we offer, subject specific, people with lived experience going through the same challenges.
Well, that wraps up this session. Thank you, Max and Orion, for this informative session on telehealth. Before we end this session today, I would like to introduce Rose Locklear, a program manager at the Oregon Office of Rural Health, who is responsible for telehealth outreach and education. Rose has an upcoming telehealth project she would like to briefly mention. Rose?
Thank you, Rondi and Max and Orion. I am responsible for telehealth at the Office of Rural Health, and as such sit on the boards of the Northwest Regional Telehealth Resource Center, as well as the Telehealth Alliance of Oregon. Both programs have received some federal funding, which are allowing us to do some work on behalf of the Telehealth Alliance of Oregon, which is to map out the telehealth services that you all are providing at your rural health clinics. And I didn't plug Max to mention mapping of broadband, but there's really a lot of application between understanding what's going on at rural health clinics. You all are the safety net providers out in your community, but really understanding what you all are providing via telehealth and making the connection back to these issues that we're having with connectivity. And also, as that conversation evolves with the rural health clinics and FQHC, C is remaining originating sites. So if we understand what's going on in our state of Oregon, we can speak to the conversation around those two topics a bit better. So you'll be hearing from me in the coming weeks about this project, and I would really like to spend a couple of moments connecting with you and understanding what you all are doing in your clinics. So thank you so much for allowing me to mention the project.
Thank you, Rose. This concludes day 3 of the Rural Health Conference. We will be back tomorrow at 9 a.m. with our first session titled Help for Quality Improvement Overload: What Really Works in Primary Care from a Decade of Orphan Experience, with Nancy Elder, Cullen Conway, and Caitlin Dickinson. On behalf of the entire staff at the Oregon Office of Rural Health, thank you for attending day 3 of the Oregon Rural Health Conference. Have a wonderful afternoon.